Hello, Dr. Moritz here again, and today we're going to talk about gastrointestinal disorders in pediatrics. If we can get to the next slide, let's see. There we go. So here's a quick view of the gastrointestinal system. Goes from the mouth down to the rectum. So some of the things we're going to talk about are in the mouth, esophagus, stomach, intestines, biliary system, and pancreas. The biliary system includes the liver, the gallbladder, and all the associated bile ducts. The first thing we're going to talk about is dehydration. The thing about children is, and those of you that have sat in my classes for the past 2 weeks have heard me say that dehydration happens very quickly in children. They do not have the ability to maintain a fluid balance in the same way that we do as adults. So it's a little bit harder to tell what their dehydration is. You will see mild dehydration is less than 5%, as your slide says, in infants, and 3% in children. Very small amounts will start to dehydrate them, and there's moderate and severe. So we have to watch these kids very carefully and very closely. In order to reverse dehydration, if it's mild or moderate, if the child's not vomiting huge amounts, if they can keep something down, we really go for PO fluids first. So electrolyte fluids, like Pedialyte or something like that. If they're unable to keep anything down, then of course we would go to IV fluids. Normal saline is what will help us rehydrate these children. So predictors of fluid loss. Change in level of consciousness. So these are just some things that will tell you that a child has had some fluid loss. They do have a change in their level of consciousness, and it's different than it is with adults, like always. And then altered response to stimuli. They can be a little bit slow, or they don't really respond at all. When very small children, infants and toddlers, get dehydrated, they're very floppy. They also will have decreased skin elasticity and turgor, very much like adults. Prolonged capillary refill. This is a really good, quick way to check and see if the child is dehydrated, is just to do a cap refill test, and it will be prolonged in children who have become somewhat dehydrated. They'll have an increased heart rate, and their eyes will be a little sunken in. If their fontanelles are still open, if they're that small, then yes, their fontanelles will also be sunken. Let's see, the earliest sign is usually tachycardia, followed by dry skin, dry mucous membranes, sunken fontanelles, signs of circulatory failure, and outside of cap refill, that can also include coolness of touch and mottling of the extremities. It's very common for these kids to mottle and to be very cool, so they'll get cold quickly. Let's see, they can be irritable with moderate dehydration and lethargic with severe dehydration. So you're also going to want to look, there's a chart on page 1174 of your textbook, and this chart has the clinical signs that are attributed to each level of dehydration. It's really important to know those because, again, children dehydrate very quickly. You can also check lab tests for older children and, of course, adults. Serum bicarb, maybe less than 13, indicates dehydration, and this type of dehydration absolutely needs an IV intervention if their bicarb level is less than 13. Also, urine-specific gravity and BUN, they're not as reliable, so you don't necessarily want to count on those as much as you would. Better to count on some of the other symptoms we talked about. So therapeutic management, mild to moderate, oral rehydration. And this is where we want to go first, unless they can't keep anything down or they're having so much diarrhea you can't catch up. Then you would want to do IV fluids, because that would be considered severe and you would need the IV fluids to replace the volume, the fluid volume. Also, of course, you need to treat the reason they're dehydrated. Why? Is it a GI bug? Is it just that they were outside playing and weren't paying attention? Are they vomiting? Why are they vomiting? So you want to treat the reason they've become dehydrated as well. Diarrhea, that involves, of course, stomach, small intestines, colon, and the colon and intestines. So it's always an itis, right? Because it's an inflammatory process. And this gives you all the different types. Acute diarrhea is a sudden increase in frequency. So diarrhea isn't always liquidy. Sometimes it's just very frequent. But acute diarrhea will have more of a liquid stool. So there is acute diarrhea will have the difference in the consistency of the stools, and it will also have the increase in frequency. This is almost always caused by some sort of an infectious agent. It can even be a foodborne infectious agent. Chronic diarrhea is something different. We'll talk a little bit about those. An increase in stool frequency and increased water content with a duration of more than 14 days. So it's acute if it only lasts for a few days. If it lasts longer than 2 weeks, you can consider it chronic. So most pathogens that cause diarrhea, they can be spread either through fecal material or they can be through the oral route of contaminated food or water, or person to person who has some sort of a problem. This daycare centers are really common. Rotavirus is the most important cause of serious gastroenteritis among kids. They get this very quickly. It dehydrates them very fast and has a 28% fatality rate. So you must be very careful with this. This particular virus is spread also fecal-oral. Almost all kids that are infected with rotavirus or are affected with rotavirus at least once before they're 5. We now have an immunization for that, as we talked about in week 1, and this is something we would encourage parents to have their children receive. So how do we manage diarrhea? Obviously, we try and orally rehydrate these children first and introduce them to a normal diet, not overly slowly, but the doc usually will tell you when they can have solid food, liquid food, soft food, whatever that person wants. Care management, obviously educate the parents regarding the reason the child had diarrhea, and also what are the early signs and symptoms of dehydration. Skin care to prevent excoriation, that would be on their buttocks. Diarrhea, because it comes through the system so quickly, can often bring some of the acid from the stomach with it, so it can excoriate the rectum and the buttocks, and you want to do good skin care to prevent that excoriation or take care of it afterwards. And then you always want to educate on preventative measures. So the opposite problem, constipation. There are multiple reasons for constipation. It can be a structural disorder such as Hirschsprung's or a stricture. It can also be a systemic disorder, hypothyroidism, hypercalcemia, and sometimes medications. Children who are on diuretics or antacids have a problem. Also kids on anti-epileptics or iron supplements will also have a constipation problem. We don't see as many kids on opioids anymore, but if for some reason they are on opioids, such as a cancer patient or something, that would also give them constipation. So some of the things that go along with constipation are painful bowel movements, obviously because it's so hard and it can get large because there's no fluid to help soften it. Blood streaked or retained stool, that can happen. The blood streaking can come from pushing through the rectum, abdominal pain, lack of appetite, and stool incontinence. Sometimes liquid stool will come around the mass. We'll talk more about that in Hirschsprung's. And then the causes, of course, we have already discussed. So encopresis, repeated and involuntary defecation in a child older than 4. By 4 years old, they should be able to control their bowels, but sometimes they can't, and it can be caused from constipation. This is frustrating for both the parents and the child, and it can really lead the child to withdraw socially. They have a difficult time with this because socially it really isn't something that people accept. So in order to manage this, we want to give them a high fiber diet, get them to exercise, and have regular toiling habits after meals. So they need to have some sort of pattern and structure to when they move their bowels. Stool softeners can help because it decreases the constipation. And of course, there's always emotional support. So Hirschsprung's, as I mentioned previously, is a problem with structure and barrier. So lack of innervation, often in lower portion of the bowel. So here's what happens. There's no peristalsis movement within the bowel. The ganglion nerves are not there in that part of the colon. So there's no peristaltic waves that helps move the fluid, the stool, whatever along above that particular area. So they can get what's called a megacolon. The rectal sphincter can fail to relax, and then sometimes they will have these stools that go around the mass that's collecting in the colon, and they come out looking like ribbons, almost like that Christmas ribbon candy. It's very thin and will kind of gather up like in a ruffling effect as they pass through the narrow segment. So the one treatment to this is surgery. They will take out the part of this bowel that doesn't have any ganglion cells and anastomose the other pieces. So typical pre-op and post-op for bowels, you have to assess the site. Obviously these kids are NPO until their bowel sounds return, and we know that they're passing gas or whatever through their bowels. IV fluids, because they're not taking any food, and sometimes there is the requirement of anal dilations to help get that sphincter back into control. This is most commonly observed in neonates or small children, and is much more common in males than females. It's thought that this is a genetic and environmental problem, but we really don't know why some kids have Hirschsprung's. Let's see. So the big thing to remember is the absence of the ganglion cells and the fact that there's no peristalsis because of that. Let's see. Failure. In a neonate, when they're first born, they don't always pass meconium in the first 24 to 48 hours after birth, and they will sometimes have bilious vomiting with abdominal distension, and they're not interested in eating. We do not always find it in neonates. Sometimes it's not discovered until later, infancy and childhood. And if it gets away and we don't find it until they're a little bit older, they will have problems with constipation, recurrent diarrhea, ribbon-like foul-smelling stool, abdominal distension, feeding intolerance, and bilious vomiting. These kids very often will fail to thrive. They'll be very tiny and scrawny. You know, most toddlers and infants are kind of robust. They're kind of round. They have cute little chunky thighs, and as toddlers they have that toddler belly and they kind of walk like weebles, but they don't fall down kind of thing. But these kids will not be like that. Sometimes they'll do a rectal biopsy to make sure there's ganglion cells in that part of the bowel. Okay, I think that's all I want to say. Okay, next. Oh, I forgot we had pictures. So here is a picture of how that works. You can see right here the largeness of the colon or the megacolon section. It can happen a little further up, but almost always happens right here in this section of the bowel. And you can see that this section of the bowel would be down here. So these kids really have a lot of abdominal pain when this happens. Okay, let's go to gastroesophageal reflux. This is a presence of abnormal amounts of gastric contents in the esophagus, sometimes in the upper airways, and occasionally will even get down into the tracheobronchial area. The problem with the gastric contents is that they cause inflammation because part of the gastric contents, again, is that acid. So that creates a problem in relation to the inflammation, which then can sometimes cause a stricture as it heals. So it can cause all kinds of problems. The resulting effects or the problems it can cause, if they reflux, is most often aspiration of gastric contents. And again, this causes terrible inflammation in their lungs. They can have recurrent pneumonia, all kinds of pulmonary diseases, esophagitis, and esophageal stricture. Because the stricture comes from the healing of the inflammation, it happens again, it heals, it happens again. What we do for, this is called GER, or GERD sometimes. GERD, there's no vomiting with GERD. But this is often gets better as they get older. The peak time for this is 4 months of age, and actually most infants will outgrow it, around 85%. However, they may need surgery if they do not respond to medical treatment. Most often it's preterm infants or infants with bronchopulmonary dysplasia. We don't really call it bronchopulmonary dysplasia anymore. It's more like an RDS kind of thing. But the problem is they have very weak muscles when they're premature. And then they have bad lungs, which we used to call bronchopulmonary dysplasia. So the combination for them is really not good. They can also sometimes have silent GERD because there's no vomiting. But these kids will be very irritable with and after feeding. Sometimes they'll arch their back after feeding because they're in pain, because the gastric contents have come up into their esophagus, but they're not vomiting. It can cause bradycardic, especially in small premature infants. So what they tend to do is have something called a pH probe, and what they often do will take the pH probe and put it down into the stomach through the nose. And and they'll have it down there for a certain number of hours, 12, 18, 24, it varies. And that will tell them how often these kids are having reflux into their esophagus. You can usually diagnose this with lack of weight gain. They're not growing. They may not even grow as long as they should. Their OFC, chest x-ray for respiratory symptoms, as I mentioned, the pH probe, and sometimes they'll do an endoscopy. But these kids, again, don't do very well. So some of the things we do to help them is give them a medication, and then also we will thicken their feeds. We've even done this with premature infants where we used to thicken it with rice. More often now they have actual thickeners. And then sometimes they'll use oatmeal because the rice doesn't always work well. But they actually have a thickening agent that they mix in with the milk. And that way it's not so chunky as with rice or oatmeal. The problem when you thicken their feeds is it's very difficult for them to suck it through the nipple when they're bottle feeding. So sometimes we snip just a little bit bigger hole in there in the nipple, but that's only if the doc wants you to do that. Also, we feed small, frequent meals. Instead of every 3 to 4 hours, it might be every 2 hours, and they would get a smaller amount. So because they get tired from sucking. And then there are also times when we will use a different type of nipple. And if you're in my class, you've heard me say this before, but there's a number. If you get the red and blue or vanilla looking nipples in the nursery, you will see on the back there's a number. This number will tell you how large or small the hole is. The larger the number, the larger the hole in the nipple. Positioning is also important. You want to always have the head of the bed elevated, and you want to hold the child in a more elevated position when you feed them. Sometimes we will give medications, Zantac, Prevacid, or Prilosec, and those can be placed in a small amount of formula, or sometimes they're just placed in a nipple and given a certain time frame before they eat. Okay, what else do I want to tell you? I told you how it was diagnosed. Treatment depends on the severity of the symptoms. So let's see. Yes, administer the medication 30 minutes before the meal. If there's a dose for every meal. If not, then you should give it 30 minutes before breakfast. And then sometimes it's morning, evening, so 30 minutes before an evening meal. If this doesn't work, they do sometimes do a Nissen and fundoplication. The fundus is wrapped around the lower portion, helping the food to stay down. Here's a picture. Some of these are reversible and some of them are not. So it will cause some issues for children their whole life. Okay, excuse me for 1 minute. Okay. There we go. So let's move on and talk about appendicitis. So appendicitis is very common. Many of you may not have your appendix. I still have mine, but there are lots of people that do not. So there are some early symptoms for this: not wanting to eat, anorexia. Children don't seem like themselves. Parents may tell you, come here, Max. Parents may tell you that the child's acting strange or doesn't have as much energy, things like that. They may have some nausea and vomiting and a mild fever or a low-grade fever. The pain is pretty general. A lot of times, kids in particular, don't always know. They just say their stomach hurts, it hurts all over. Eventually it will localize, and we check it with by checking for rebound tenderness in the right lower quadrant, and that is called McBurney's point. Sorry, it's storming tonight. It's Sunday night, and Max, my dog, is a little bit worked up. Okay, so the big thing to remember is if the child's complaining about pain and all of a sudden the pain goes away and they're feeling great, that is not a good sign. That means that potentially this child's appendix has ruptured, and that would put the infectious materials throughout their abdomen, which is not a good thing. So we would want to notify someone immediately at that point. Some of the diagnostic testing are CBC, UAs, and CTs. If they have a ruptured appendicitis or appendix, it will take 7 to 14 days of antibiotics. If it is not ruptured, it would be a post-op recovery time frame. So pre-op, obviously they're NPO and they would be on IV therapy. You would want to make sure you would position them to be comfortable, and prepare them for surgery according to the physician orders. Most times the surgery is done laparoscopically, as long as it's not perforated. Post-op, typical post-op orders: monitor vital signs, maintain IV, advanced diet is tolerated. Always, like any other post-op, we always want to assess for pain. And again, remember, children will not tell you they're in pain. So you have to discover it by checking them out and asking the appropriate questions. You want them to start moving around as quickly as possible. And of course, you want to assess their sight. Most kids recover from this very quickly if it was not perforated. If it was perforated, they probably are going to have peritonitis at some level. So again, IV antibiotics, they'll be NPO longer, and they will have an NG tube for a while. And it will be on low continuous suction to pull out whatever is in the the stomach. Sometimes they have a drain place to help get rid of the infectious materials in their abdomen. Their pain management will be slightly more assertive than if they just had a regular appendix removal. And they will not be going home as quickly as someone whose appendix did not rupture. Okay, now we're going to talk about inflammatory bowel disease. There are two specific gastrointestinal conditions: ulcerative colitis and Crohn's disease. This is an autoimmune problem. We do not know why these kids get these problems. Their prognosis is very specific to when it starts for them and how quickly it comes on. Most often they will respond to medical treatment, but it depends. If the involvement of the bowel is heavy and the disease is assertive, that might not be, their response to medical treatment might not be that great. So here are some of the initial signs for the two diseases: diarrhea, rectal bleeding, abdominal pain, fever, malaise, anorexia and weight loss, and anemia. Anemia because they will have some rectal bleeding. Sometimes they will have a little bit of bleeding in their bowels as well. They may include some vague symptoms, failure to thrive or growth failure, depending on how old they are. And a lot of times their joints will hurt. It seems like most autoimmune problems and even some problems that are inflammatory always tend to cause joint pain. So specifically, Crohn's disease is the inflammatory and ulcerative disease that affects the alimentary tract from the mouth to the anus, so the whole thing, the full thickness of the intestine, and it skips some areas. So it's interesting. It will cause a problem here, cause a problem there, cause a problem somewhere else, but all the areas in between, no problem. Will also cause fissures and fistulas. And then the diarrhea will have occult blood in it if the colon is involved. It will, the child will bleed further up than just the rectum. These kids have horrible cramping. The abdominal pain is really bad, and eating only makes it worse instead of better. A lot of times these kids will not grow well because they're not getting the same nutritional value that their counterparts are getting, or their the iron is low, all of those things. They don't tolerate food as well. And the food they do tolerate might not always be what they need. So they will have weight loss. They'll be small, thin children, and they'll have a lot of fatigue. They can have an intestinal blockage, but not always. And their abdominal pain is almost always in the right lower quadrant. Okay, so in order to find out exactly what's going on with these children, we will do the usual blood tests of CBC and electrolytes, but liver enzymes and SED rates will also tell us things. SED rates in particular are really good for inflammatory type autoimmune diseases. And then CRP will show you a little bit more about white count and if there's an actual infection. Sometimes that will show up in a CRP before you see a left shift in a CBC. Urinalysis, stools, they'll check that for white blood counts and occult blood. They will do a specific IBD lab panel, an endoscopy, a colonoscopy. Depends which one they'll do, depending on how high they think the problem is. And an eye exam. And I know that's kind of unusual that they would do an eye exam, but think about it. The dehydration, number one, but more importantly, if they're having such pains, if they're bearing down a lot, that can cause some problems in their eyes. So how do we treat this? The biggest treatment we have is corticosteroid therapy because it can potentially put them into remission. This will help a lot in regards to the inflammatory process. Antibiotics, if there's bacterial agents in their bowels that are causing problems, because the antibiotics will cause, the bacterial agents will cause more gas. As bacteria breaks down, it creates gas, and that's where some of that pain comes from. So the antibiotics will eradicate the inflammatory process because it kills the bacteria that's causing the gas. Let's see. So this infliximab, and then immunosuppressives. There is no cure. These kids will have this their whole life. The whole point of this is to just decrease the inflammation because that will cause the most trouble. If you can get them to have good nutrition, that's always great. And then, of course, we don't want them to be in pain. So we will want to provide some relief of those symptoms, and the corticosteroids do a really good job of that. The problem with corticosteroids, like any steroid, is it gives you a higher possibility to get an infection. There's always two sides to every coin. So nutritional support during this time can be a modification in the diet, vitamins, oral supplements, or sometimes if they're incredibly severe, they may need to be on TPN for a certain amount of time. So up to 70% of children require surgery because they might have fistulas or they might have an obstruction from the inflammation, and that would need to be removed or reduced. Sometimes these children need an ileostomy or a colostomy, and that creates its own problems, especially for teenagers. You know, if school-age kids, and I've said this in my class, school-age kids, if you can explain something to them by giving them very specific, concrete instruction and direction, they will follow your instruction to the letter. If you give them 10 steps, they will follow all 10 steps in the order you ask them to. It's when they become teenagers that it becomes a problem because they're trying to be independent, they're trying to find themselves, and having an ileostomy or a colostomy is very difficult when they become teenagers. So now let's talk a little bit about ulcerative colitis. And ulcerative colitis is a recurrent inflammatory and ulcerative disease. This mostly is in the large intestine, and it could be a more superficial inflammation than the other Crohn's. It doesn't get quite as bad. However, they can have frequent bloody stools, and these kids too will also have abdominal pain. They will also be very tired. These kids tend to be dehydrated. The Crohn's disease also, these children can be dehydrated. And because our electrolytes come from our food and all of that is absorbed through the GI tract, their electrolytes will be a little bit out of whack. They will also lose weight very quickly because of the fluid and the nutritional value. They become pale and they're tired, again, because of the loss of blood, and they will be low in iron. Sometimes these kids will have between 10 and 20 stools a day. It's a really difficult disease. So we know what's going on with them if we do a CBC, electrolytes, obviously, liver enzymes, again, the sed rate, and CRP. They will look for blood and C. diff. So if these kids get C. diff, it's much worse than if someone else gets C. diff. And they will do a tissue biopsy to know exactly what they're dealing with. Treatment. So the drug of choice for this is also corticosteroids, along with an antidiarrheal, because these kids will have very massive amounts of liquid stool. And they will try and induce remission into these children as well. They don't use antibiotics as often because there's not always the risk of an infection or an infection in general. But they will use sometimes immunosuppressives. Obviously analgesics. It says narcotics for pain in your book as well, but as you know, we're not using narcotics as often as we used to. I know one of the drugs that has replaced narcotics is gabapentin, which is actually for nerve pain. I don't know if they use gabapentin in these children or not. I looked in the research and couldn't find anything. I know they're using it with adults, but I also know we're trying to stay away from narcotics for kids. The narcotics for kids, the one they most often use is morphine, but if they can use regular analgesics without using narcotics, so much better. Nutritional support, ways to actually help the ulcerative colitis nutritionally, and then surgical intervention is almost always needed. I guess I shouldn't say almost always. It says 25% in your book, but it will provide a cure if they are able to get all of the pieces. Okay, so that's all for that. Biliary atresia. So a progressive inflammatory process that causes bile duct fibrosis. These kids end up with an obstruction of the bile flow. And as you all know, the bile is what helps us digest fats. So they will have a problem with fatty foods. It can cause cholestasis, resulting in jaundice. Jaundice is almost always the first sign of kids having biliary atresia. And it will show up in their eyes almost always first, but their skin will also have a yellow tint to it. Eventually, this will progress to a fibrosis, and sometimes it will progress to cirrhosis of the liver. We don't know why this happens, but we know that it does, and it causes problems with their liver. The theories as to why it happens: some people think it's infectious, some people autoimmune. So, but we really don't know for sure. Signs of this stools are going to be chalky and white. And this is because the lack of the bile in the system. Jaundice of the skin and sclera, as I mentioned, and their liver will enlarge. They will have an abdominal distension, and you will actually be able to feel their liver when you look for it. Jaundice is almost always the earliest manifestation, and as I said before, it can be first observed in the sclera. Let's see. If this is in a newborn, sometimes they have neonatal jaundice, which could cloud the issue here. So you might not see, 2 to 3 weeks later, you might see the jaundice in the sclera, even though the jaundice, the neonatal jaundice, has somewhat disappeared. These kids will still be jaundiced, and they will not gain weight well. So some of the diagnostic tests, they'll do liver enzymes, an ultrasound, a biliary scan, and a liver biopsy. Treatment. There is something called a Cazé procedure, and this will allow 1/3 of the infants to become jaundice-free and regain normal liver function. But others, it will cause more liver damage, but they can be supported with medical and nutritional interventions. The remaining 1/3 will require a liver transplant. So this can be a very serious disease. Most successfully, the bile duct surgery is performed at 10 weeks of age. After that, it might not be as successful. And if they don't see it early enough, or this Cazé is not successful, again, the final 1/3 of these kids will need a liver transplant. There's vitamin and calorie support. Because there's no bile, the fat-soluble vitamins A, D, E, and K are not absorbed. So that can be a problem. And there are special formulas for these kids to take. They have what they call medium chain triglycerides, and it will help them with that. So let's see. So the Kase procedure will improve the prognosis, but it really isn't a cure. And these kids have some long-term survival rates, but some of them do not survive very well. And they will have liver failure if they do not get a transplant. Okay, let's go on to the next. So cleft lip and palate is fairly long. So I'm going to stop this particular audio here, and there will be a second one for the rest of GI.